Pat Smith here. Greetings from Columbia, Missouri. I'm sorry that I could not be with you all in person for this first meeting of the Internal Bracing International Study Group, but I made a prior commitment to my wife a couple of years ago that I couldn't change. In any event, hope you all are having a great time so far. Gordon asked me to talk about ACL IB reducing ACL revision rates at 5 years. The problem is there are only 2 studies in that regard. One is his and the other is mine, which I'll get to later, but that would be a pretty short topic. So I thought I'd do is just run through my journey with internal bracing for ACL reconstruction and my rationale. My rationale for augmentation for ACL reconstruction is pretty clear, as we still have a problem in 2024 of ACL graft re-tears. These particular studies highlight that. Kate Webster from Australia showing high failure rate in younger patients, 18% overall with hamstring graft, 28% failures, males under the 18. Cruz showed similar numbers, BTB autograft failure 8.5%, hamstring autograft 16.6%, and allografts almost 26%. In young patients 19 or younger. Moon group, same thing, 7% for BTB autograft, 13% for hamstring autograft in these younger age patients in their study at 17 years old. So for me, my primary purpose with augmentation is to avoid ACL graft re-injury. I'd like to be an ACL surgeon with no re-tears. I know that's a lofty goal, but I think internal bracing is getting us closer. I have tried to take a scientific approach with internal bracing for ACL reconstruction, with this scientific pyramid, first working on translational canine studies, then going to the biomechanical lab, and then finishing up with clinical studies, which I am now publishing. This was an important translational study that I published based on the fact that I got a lot of pushback from surgeons, particularly in Europe, about use of the internal brace as an artificial ligament. So I went to the canine lab with Dr. Jimmy Cook here in Missouri, and I put 6 fiber tapes across the ACL in dogs. I cut 3 of them to look at the worst case scenario of exposing torn tape to the joint. Followed them for 6 months, which is 2 years in human time, and we found no articular cartilage changes and no synovitis, as you can see in this slide. So this was a good translational model for safety for internal bracing. This paper that will be coming out soon at OJSM is more of a human safety study of internal bracing. I looked at 25 of my patients with a quad tendon autograft, young at age 20, average, over 2-year follow-up. They all had MRI studies, which showed an intact graft. And I had an independent radiologist look at the ACL-PCL ratios for APR, as well as what's called the MOC score for joint inflammation. And the radiologist showed us there was no difference compared to traditional ACL reconstructions without tape versus my quad tendon grafts with tape. So this is, again, more of a human safety study for internal bracing. Going back to the canine model, which is a good model for ACL reconstruction, it's a double bundled structure. But the difference with a dog, if they tear their ACL, is typically they have an extra-articular stabilization procedure or maybe a slope leveling tibial osteotomy because of the high tibial slope most canines have, greater than 30 degrees. So it's a harsh model for ACL reconstruction. I had the idea that perhaps we could do an intra-articular ACL reconstruction despite the high slope by adding an internal brace. So Dr. Jimmy Cook and I operated on 10 dogs. We did this all inside ACL reconstruction. You can see here, cut the ACL, removed it, placed it with an allograft with an internal brace, suspensory fixation, just like we would do in the human. These animals were followed for 6 months. They had x-rays, clinical stability examination, including lameness, force mat, pain threshold, range of motion, effusion. Dr. Cook scoped them at 8 weeks and 6 months, and they were sacrificed at 6 months for gross evaluation, biomechanical testing. This table summarizes our clinical results comparing the normal limb to the quad tendon internal brace allograft reconstructed limb, and you can see across the board, no difference side to side. Lameness, function, percent TPI, is how much weight bearing they did on the operated limb, pain, effusion, stability, same side to side. This slide represents our biomechanical results. 4 millimeters pull to failure is what it takes to disrupt the ACL and the canine. You can see 1 millimeter, 2 millimeter, 3 millimeter, up to 4 millimeters. We were the same side to side, reconstruction to normal knee, and stiffness was the same as well. We published our data in the Journal of Knee Surgery, and in essence, we were able to show that you could do an intra-articular ACL reconstruction successfully in a dog with high tibial slope, not previously reported, with use of the internal brace, which I think was the key here. Relative to biomechanics, everyone in the room there knows the key is the independent passage of the tape separate from the graft. And seen here, what we know is that this allows for load sharing, not stress shielding. Acts as a dynamic safety belt for higher failure loads to protect the graft, reduce elongation, and it's simple to do. In terms of scientific evidence, this was our first published study on the biomechanics of use of the tape with small and standard diameter grafts we published 5 years ago. This slide nicely summarizes what we did. First, we looked at a small 8 millimeter graft. This is called the ACL functional zone. If we test a graft, we'd like it to be in this zone, which is the normal hysteresis curve for the ACL based on the literature. We tested at 250 newtons and then at 400, which is a significant load, both to 1,000 cycles. Here's a small graft, no tape. It's out of the zone, displaced. We put the tape in, ends up in the zone. Higher load, 400 newton load. Look at the displacement now without a tape with the graft. Put the tape in, we're in the zone. Notice this is fiber tape loaded to 250, 4 millimeters of laxity, 6 millimeters when we loaded to 400 newtons with the tape. So the tape has some innate give to it. So we found with the smaller graft, we had this irrecoverable elongation. We recovered it though, 51% improvement by adding the internal brace. Next, we tested a larger standard 9mm graft as we wanted to make sure we did not overconstrain by adding the tape. Same testing model, 250 newtons to 1,000 cycles, 400 to 1,000 cycles. Without the tape at 250, we were pretty much in the zone. Not bad. Adding the tape, we kept it in the zone. We did not overconstrain. At 400 newtons, though, look at the laxity present with the graft without the tape. Put the IB in. We're in the zone here. Notice again the fiber tape, the innate laxity present, loaded to 250 newtons, about 4 millimeters, and 6 millimeters loaded to 400 newtons. So in this particular model with the larger graft, we had a 26% improvement by adding the IB to get us into that functional zone. So this study showed that lower loads were on the graft until displacement began, and then the fiber tape kicks in at the higher loads to reduce load on the graft, so there was no stress shielding. Unfortunately, despite our best efforts, there were still doubters out there that said we were stress shielding our grafts, so we designed the second study where we looked at optimal tracking. Here's our experimental setup, and basically we wanted to know when does the tape go from slack to tight, and that's when the tape would start to carry load. This is the money slide from that study. Load on graft is in red, load on tape is in blue. This is our smaller 7mm graft this time versus a regular 9mm size graft. You can see what happens. The majority of the load in both cases is on the graft. For the smaller graft, the tape kicks in at 200 newtons, but overall, only 30% of the load is on the tape, 70% on the graft. For the larger 9mm graft, the tape kicks in at 300 newtons, and overall, only 20% of the applied load is on the tape, the majority, almost 80%, on the graft. So the key findings of our second study are summarized here. The key is the graft is seeing the majority of the load. For the smaller graft, the tape kicks in at 200 newtons, and only 30% of the total applied load goes to the tape, the majority of the graft. For the larger graft, it kicks in the tape at 300 newtons, and only 21% of load is transferred to the tape, the majority of the graft. So we feel what's happening is the tape is increasing the stiffness of the construct at higher loads to decrease the elongation, so there's truly no stress shielding. One more biomechanical study I want to highlight is this one where we looked at BTB with internal brace because it applies directly with my recently published 5-year clinical study with BTB and internal bracing. We looked at a porcine bone allograft model, BTB full construct, screw versus screw fixation versus an ALD and screw versus an ALD on the femur with an IB and screw. This slide summarizes our result. The IB group was 31% better, controlling cyclic displacement. Ultimate load and stiffness were better with IB, but not quite statistically significant. This is how I do it clinically. My femoral bone plug is fixed with an ALD with the tape, pass through it, through the button. The tape is posterior in the femoral socket. I fix the tape first in full extension, utilizing a swivel lock anchor. Bone plugs over the tape and screw on top for my fixation on the tibia. Whenever I do an internal brace, I always fix the tape first in full hyperextension of the knee, then the graft is fixed second on the tibia. I always cycle the knee and retension intraoperatively in full extension to avoid any creep in the construct. It is also important to note that the suture tape is always lax at 90 degrees of flexion when it's fixed in full extension. That corresponds to this study published by Lou DeFreidt out of Duke, which showed the ACL lengthens 3 millimeters when the knee goes from 90 degrees to full extension. And here's where the science meets the clinical case. Looking at the tape at 90 degrees of flexion, it's always lax when you probe it. Now let's get to the 5-year follow-up studies on internal bracing for ACL reconstruction. There are only 2. Gordon's study published last year at AJSM, and then the study that Adam Daniel, my research assistant, and I just published here in arthroscopy last month. This is a summary of Gordon's study, 97 patients, 52 hamstring, 45 BTB. Note the mean age of 35. Hamstring grafts were a bit small in diameter at 7, BTB 8.3, all at 6-month clinical follow-up, and PROMs were collected greater than or equal to 2 years with a mean 5-year follow-up. All the PROMs improved postoperatively, although there was a decrease in Tegner, which is quite common, as patients in ACL follow-up studies always are a bit less active. There was only one failure. That was a BTB patient, overall rate 2.2%. Notably, he had no failures in the hamstring group, which is remarkable, as I'll show you my hamstring data a bit later. Not near as good, but I think the difference was my age was much less than the average of 35 in this study. This is a summary slide of our recently published BTB paper in arthroscopy last month, 5-year follow-up, 114 patients. We had a control group, so we had 52 with suture tape augmentation, 62 without, mean age less than 19, high-risk group, mean follow-up greater than or equal to 5 years. We had no re-tears in the BTB plus suture tape group versus 5 re-tears without the tape. That was statistically significant. The reviewers were tough on us. They made us go back and measure tibial slope and look at our ACL tunnel positioning to make sure we weren't selecting out the tougher cases for the no IB, and that was not the case. Notably, greater than 85% returned to full capacity to their initial sport that led to their first ACL tear. This is a quick video of how we did it. AM portal drilling for the femoral socket, as you can see here. We used the retrocutter for the tibial tunnel, which was full. I'm going to pass the bone plug up into the femur with an ACL tightrope with the tape passed through the button. So you'll see it pulling across now. There's our bone plug. There is the adjustable loop device for our fixation. Here's our graft fixed on the tibia, tape first, then the bone plug over the top. There's our tape, loose inflection behind the graft. Good position. I would just like to finish up and show you a couple other clinical studies I've recently published with use of other grafts with internal bracing. This was my first clinical study published last year in OGSM. I had 100 internal brace patients versus 100 controls. Mean age less than 20, high-risk group, high activity level based on marks, 13.4. Here's the findings. IB group, 1% re-tear versus 8% without an IB. That was statistically significant. Our problems were all better. The mark score did decrease in follow-up, which again is common. Our KT readings were the same. We had no motion loss with IB, no over-constraint. This was a study we did over COVID. We had 252 patients, internal brace, independent, multiple grafts. We had to do a bit more foam follow-up here. Mean age 23.6, follow-up over 3 years. Our re-tear rate was 0.8%, less than 1% with multiple grafts. This is my quad tendon and IB data, which is my most favorite graft nowadays. Just published in Arthroscopy Online 10 days ago. We looked at 60 high school and collegiate athletes, mean age 16.8, young, follow-up greater than 3 years. We did have subsequent surgeries on the ipsilateral knee, 7 meniscal, 3 for scar tissue, but notably no graft failures. All our problems improved. The majority achieved MCID. KT1000 testing was good. 90% return to sport. 6 patients who did not return to the same level did so because they graduated, so they weren't playing any longer. This is my hamstring IB data coming out in OJSM soon. We had 104 patients, 36 suture tape versus 68 control. Mean age less than 22, follow-up greater than 4 years. I had a 5.6 revision rate with suture tape versus 24% revision rate without a tape. That was obviously statistically significant. No difference in a return to sport or problems or complications. What we found is the younger patients, high school athletes, and those with higher post-op Tegner levels had a higher risk for re-tear. But I didn't do as well as Gordon. I think part of the problem was my young active patients with my hamstring grafts. So suture tape augmentation for ACL reconstruction. It's easy to use. There's no change in normal ACL reconstruction workflow. Inexpensive and fast. It's reproducible. I think for me, I sleep better at night knowing I have the tape in place. Less graft re-tears I've shown, and this idea of the graft serving as a seatbelt for load sharing. It's also cost effective, avoiding revisions, avoiding athletes missing a second season by having one successful ACL reconstruction to begin with. This slide represents my publication journey here with suture tape augmentation from my translational studies that we've published to biomechanical studies to now my clinical follow-up. So it's been a long journey over the past 10 plus years, but well worth it with less re-tears for my patients. In conclusion, we have strong peer-reviewed scientific studies confirming these evidence-based conclusions that suture tape is safe to use. It's not an artificial ligament. The importance of the suture tape biomechanically being independent from the graft, both in terms of position and fixation, which I always do in full extension or hyperextension. First, the graft second, no stress shielding of the graft. Instead, we see load sharing at higher loads to protect the graft, this seatbelt concept. And clinically, it protects our grafts from re-tear. Gordon showed it in his hamstring group. I showed it with our BTB group. And I've had also good success in my quad tendon group, which I prefer as my #1 graft these days. And in my hands, it definitely is superior with a quad graft or BTB graft over a hamstring graft. Thank you very much, everyone, for your time and listening to my presentation. Again, I apologize that I could not be there in person, but I hope you all have a great meeting there in Milan. Thank you.